I'm Benjamin Levy. I'm an associate professor at the Johns Hopkins School of Medicine, and I'm a thoracic medical oncologist. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So anytime a patient comes to my office for that first visit, I talk to them about the various subtypes of lung cancer. And 15 years ago, 10, 15 years ago when I started, it was a very easy discussion. It was a 30-second discussion. There's non-small cell lung cancer and there's small cell lung cancer. And those are the two broad types of lung cancer. We know small cell lung cancer is about 10 to 15% of all lung cancer. It's less common. It's intimately associated with smoking. We make that distinction between small cell and non-small cell, specifically small cell, by what it looks like under the microscope and what the immunostains are. So these are protein stains on the tissue that help discriminate between small cell and non-small cell. So small cell is 15% of all lung cancer. And again, it looks a little bit different under the microscope. It has a little bit different immunostain pattern when the pathologist does the staining. And then clinically, it's more commonly associated with patients who are heavy smokers or former smokers, but who do have a smoking history. Non-small cell lung cancer is about 85% of all lung cancer patients. It also looks a little different than small cell under the microscope and also has different immunostains. Within non-small cell lung cancer, there are two broad categories: squamous cell lung cancer and adenocarcinoma of the lung. And the most common subtype of non-small cell lung cancer is adenocarcinoma. So that's where I used to stop 10, 15 years ago. That's all we really knew: small cell lung cancer and non-small cell lung cancer. And within non-small cell lung cancer, subtypes of squamous cell lung cancer and adenocarcinoma. But the discussion has to go deeper than that now, because I think what we know, at least about adenocarcinoma, is that there are molecular subsets of adenocarcinoma, and which is the reason why we need to do molecular testing for patients. And then there's also something called PDL1, which is a protein staining that also has to be done on patients with adeno and squamous cell. So it's gotten a little more an in-depth conversation on the subtypes of lung cancer. It's a little more nuanced, it's a little more detailed, but I always do start with that small cell, non-small cell determination, and then within non-small cell, that squamous and adeno determination, and then within the adeno population, the molecular subsets that comprise the adenocarcinoma. So who knows, if you would ask this question in another 5 years or even 2 years, I may have a different, more in-depth answer than I have for you now.